Dr. Ferrell, on behalf of the Sigma Theta Chi International Board of Directors, I am personally delighted to congratulate you with this award. As someone who has participated in several of your LNEC programs, I can vouch for the impact it's had on nurses that I work with, and I think you're clearly an example of a researcher who's made an impact not only in North America but around the world, so we're delighted to honor you this way.
Ladies and gentlemen, I present to you the 2013 Episteme Award recipient and our Plenary 2 keynote speaker, Betty Ferrell.
Good morning, everyone, and thank you so much for being here and for this wonderful collective of nursing knowledge and dedication around the world. It is indeed my incredible honor to accept this award, and I hope that you know that everything you just heard about my work, I can promise you I've done not one single thing alone. I'm a part of a team of wonderful colleagues around the world who are working together in this project and all of the projects in our work in palliative care. I wanted to thank two of the people who are here who were a part of my nomination for this very prestigious award, Dr. Mary Lou Kopp and Dr. Judith Pace. I also really want to thank Sigma Theta Chi International for the role that they have played in my professional career, and I think the lives and careers of nurses throughout the world. This award comes at a really significant time because as I looked back at the dates, as I was notified that I would receive this award, I realized that this year marks the 30th year since I was inducted in Sigma Theta Chi as a graduate student. Little did I know, 30 years ago, the path that my career would take and the many opportunities that I would be afforded. But one thing I know for sure, one thing I know very clearly, and that has become even more clear in the last 10 years as I've been involved in international work, is that when nurses are educated and when nurses are empowered, it means patients and families, societies, the public, receive a much higher quality of care. And so thank you, Sigma Theta Chi International, because your advocacy, your leadership, your place for our profession in advancing nursing knowledge internationally matters to patients in villages and huts and towns and communities around the world. For all of you who are in the room who are students, doctoral students, graduate students, those of you just beginning a nursing career, I particularly want to honor you because you are beginning the most incredible adventure of your life, and I wish for all of you that you would have the great opportunities that I've had to touch lives and to be inspired by my nursing colleagues. I also want to thank the Baxter International Foundation because each of us in nursing know that our educational programs, our clinical services, our scholarships, none of these things are possible, and certainly in these economic times, without people who believe in nursing. And so thanks to the foundation, thanks to this very important organization for all that you have done to make this possible. I'm here today to share with you my work that I think represents the things that I've been honored for today, I and my team, for our international work in advancing palliative care. And so I will share with you these words about the global imperative of palliative care. I do this to share with you what we have accomplished, but hopefully, even more importantly, what is the work that is yet to be done, and what are all the opportunities for each of you to be a part of this work. One of the other things that I've come to realize so acutely throughout the world is that palliative care exists not just for people with cancer, not just for the oldest patients, but palliative care is important for children who will die at the time of birth in underdeveloped countries, in neonatal intensive care units, in pediatric units, in long-term care facilities, in homes, in our growing geriatric populations. For every population and every clinical setting, excellent palliative care is an important component of excellent health care. And so we all have an opportunity to participate in this growing field of palliative care. Just to begin and think about all of this work, I take you to a village in Kenya. I was contacted many years ago by a nurse. Her name is Joyce Marette. I'll share a little bit more about her later. But Joyce contacted me several years ago and said that she was a nurse working in Nairobi. Joyce's story is that she had left her children and husband behind in a small rural community in Kenya because she wanted to become a nurse. And so Joyce went to the big city, to Nairobi, and she became a nurse. But her dream was to go back to her small community so that she could begin to impact end-of-life care for people in incredibly remote areas here in Africa and Kenya. Joyce wanted to be the first nurse to do research, the first nurse to use knowledge and evidence to change practice, and in her case, she wanted to do wound care in the seriously ill and dying. Joyce contacted me and asked if I would be a research mentor because she was applying for a research grant, a first experience, and so I agreed to be her research mentor. A few months later, she contacted me to share the great news that she had received the grant, and then she said, "Oh, by the way, I forgot to tell you, part of being my mentor is that you're supposed to come here to Kenya." So I and my colleagues went to Kenya and helped Joyce to carry out the first training course there, where we trained over 200 professionals, and we learned, of course, a lot about our colleagues in Kenya. The hut you see in the background is the hut that was actually the schoolhouse where Joyce lived as a child. And after Joyce became a nurse, her community offered her to give her this hut to come back and start her nurse-run clinic in Kenya. So my work today is dedicated to nurses like Joyce throughout the world because they're the real heroes of improving end-of-life care in every corner of the world today. It's with great gratitude to the LNA Project team and to all these professionals throughout the world who, as we sit in this room today, are improving care of the dying. The numbers are enormous and we can't ignore them. If we start, for example, with just the fact that 570,000 people die of cancer in the United States every year, but of course that's just one figure and one group that we've addressed. But approximately 7.6 million people die from cancer in the world each year. And of course, there are far more millions of people who die from TB, malaria, and AIDS. As I've traveled around the world and we've made rounds in communities and hospitals, it always strikes me that most of the people we see have cancer, TB, malaria, and AIDS. For each of these people, though, we need to realize that the end of life is not just failure, it's not just an end. The end of life is an opportunity for profound meaning, healing, comfort, and growth. And it is through the hands, the voice, the work of nursing that we can transform the experience at the end of life to, in fact, be a profound, sacred, healing experience. But absolutely none of this would be possible without expert nursing care. So the pictures that you see are my colleagues, Dr. Judith Pace, who's here with me today, Dr. Nessa Coyle from Memorial Sloan Kettering, who, as I speak today, is in Kazakhstan, carrying out one of our courses there, and Patrick Coyne, who is at Virginia Commonwealth University. This core of colleagues, with many, many others around the country and around the world, have taken the end-of-life curriculum to many, many places. Throughout the world, caregivers are applying the clinical knowledge and scholarship of nursing to improve care of the seriously ill and dying. There are many differences as we travel around the world, but one of the similarities is that in every one of the 77 countries that we've touched, it is nurses who are at the bedside of the seriously ill and dying. It is nurses who are asking questions, why can't we do a better job? It is nurses who are advocating for access to pain medications. It is nurses who are starting hospices. These nurses are working collaboratively with physicians, public health officials, ministers of health, chaplains, social workers, but nurses are leading the way in palliative care as an incredible part of our public health system. As I thought today how I could really even begin to summarize the work that is going on by our wonderful nursing colleagues around the world, I summarized for you what I consider 5 key themes of what it means to be applying the evidence of palliative care research to the bedside of the seriously ill and dying. The 5 themes, I think, really do capture what I've observed in my nurse colleagues around the world. The first theme is that nurses are changing the paradigm of care. Nurses are working in countries where, until very recent years, it has been absolutely taboo to even say the word death, dying, or end of life. Nurses are breaking important ground in countries where it's still not acceptable for patients to even be told their diagnoses. Nurses are breaking ground in countries where if a child dies in childbirth, the child is taken away from the mother and family never even have the opportunity to see the child. Nurses are changing the paradigms of care, and when we make these important changes, care happens differently. The second important theme is that we are creating expertise and knowledge in palliative care. One of the mantras that we use in the LNIC project is, nurses cannot practice what they do not know. Nurses cannot practice what they do not know. And what that means is that if we expect the nurses of tomorrow to be at the bedside, relieving pain, being culturally respectful, addressing ethical issues, providing compassionate and competent care in the last hours of life, it will be because educators, like many of you in this audience, have prepared those nurses to do this work. The third theme is fostering nursing presence. As all of you know, providing compassionate and competent end-of-life care is not just a matter of teaching nurses what medication to give, what dose. It is a matter of teaching nurses how to be present to dying people. We have been in many countries around the world who have nothing more than paracetamol to give patients who have severe pain and symptoms at the end of life. And yet we have seen nurses, through their presence, who provide tremendous comfort to people who are dying. The fourth theme is that around the world, nurses are making incredible progress in expert attention to the body and to the relief of symptoms. It is, in fact, our role to be advocating for governments, through ministers of health, through public health programs, through the World Health Organization, through all of the ways that we can to get access to medications. Just last week at one of our LNIC courses, we included 2 guests who were with us in Washington, D.C. from Swaziland. This month, Swaziland will have, for the first time, morphine to give to the millions of people who are dying there, still a country with more than 40% of people with the HIV/AIDS. And yet they have no promise, no idea if morphine will be there next month. And so there is much work that we have to do to get access to medications, but then to ensure that providers have the ability and the knowledge to treat symptoms and pain. And the final theme is that palliative care should be seen as a vision of the end of life as a spiritual experience. The first theme is challenging the paradigm of care. And what I want to do is just really share with you several photographs and some faces of nurses around the world who are doing amazing work of changing the paradigm of care. The care for so long in our country and around the world has been that good care means that we do more, that we build more technology, more intensive care units, that we prolong life. And yet for many people, we are beginning to rethink some of those values and goals. We are beginning to imagine health care that honors people's lives at the end of life. Many years ago, 2 nurses, David Kahn and Rick Steves, did some amazing qualitative work on the role of witness and moral agent. What David and Rick shared at that time was that nurses are the people often closest to the patient across settings when they are at the end of life. And what they described was that the role of nurses, that we have the privilege, the absolute privilege of being the first-hand observers. And that being there, we have the ability to provide voice. In nursing, and certainly Sigma Theta Chi has been an incredible advocate, that as nurses, our job, our mission is to advocate for the underserved, for the least empowered. And we also often think of ethnic groups, we think of young or old. But it is my experience that people who are seriously ill and people who are dying are some of the least empowered people in the world. And so, as these nurse theorists taught us, that if we can become the voice for the seriously ill and dying, if we can be the first-hand observers there to tell the story, then in fact we can do much to change care. They also told us that our role as nurses is to play a ceremonial role, ritual. I'll share an example a little bit later of a wonderful nurse, Julie, who has started one of the model hospice programs in Kenya. What Julie does is to not only try to get access to medications, she has built a place where people can come to die. She has made this self-sustaining, she even built the mortuary so they could provide this end-of-life care for patients. But what Julie also does is to orchestrate rituals, including the ability for family members, for young children to have memories of their parents who are dying. As nurses, we are the expert witnesses. We can tell the story because we have been there. And most importantly of all, nurses are visionaries. Everywhere we travel in the world, we hear the stories of nurses, and they tell us what it's like to have no medications, to have still 30 to 40% of children die before school age. Even in developed countries, what it is like when patients still continue to receive life-prolonging therapies when the goals of care should be focused on comfort. But the real difference is the nurses who are changing the world are nurses who have a vision. It could be better. These are nurses who can tell you what good care would look like and what it would be like. People around the world ask us, what is the definition of palliative care? There are many definitions that I could share with you, but my favorite definition of all is good end-of-life care is the kind of care that you and I would want if we or someone we love is dying. That's what each of us in this room should be working toward. The second theme is that nurses involved in palliative care are creating expertise and knowledge in palliative care. We've had the opportunity to do a lot of work throughout Eastern Europe, many former Russian states now developing democracies, nurses who are at the forefront of developing healthcare systems. We have been in 6 of the 7 continents, and what we have seen is that we cannot change practice until we advance knowledge. We have been in several countries, and I can share one of our first Eastern European experiences. We were inviting countries to come who were developing and to learn palliative care, to integrate palliative care in schools of nursing. When we began to receive the applications for the faculty, we were a little confused because we realized that the applications were coming from physicians. When we tried to make contact and clarify, what we were told is that these are countries for whom nurses could not be taught by nurses. Only physicians could teach nurses. And so we brought these physician educators together and found that they were actually very compassionate, very dedicated to professional nursing. And now, these years later, I'm very pleased to tell you that we are seeing the nurses that have been trained now become the faculty. I'll share with you one of these nurses later in Romania who has now contacted us to say with the money that we have provided, she is now starting a PhD program. So changing nurses one by one changes the profession of nursing, but most importantly, it changes the way that care is delivered for patients, especially for patients at the end of life. The End of Life Nursing Education Consortium started in the year 2001. We started with a group of about 5 nurses sitting at a table just like in front of you with a white tablecloth, blank paper in front of us saying, oh my gosh, what should we do? What should we teach? And because of the evidence base of nursing, because of the thoughts of nurses, we began to say, well, what are the key elements of good end-of-life care? And so the domains, the modules of LNIC became developed. The domains include a focus on palliative nursing care. What does nursing care look like when our goal is not to rehabilitate the patient, cure the patient, but when our goal is to comfort the patient? The second domain is good pain management, because people will not have the opportunity to experience death as a sacred experience if they are dying in severe pain and suffering with symptoms. The third module is symptom management, because we know that people who are seriously ill have not only pain, they have delirium and anxiety and depression and dyspnea and a host of other physical symptoms. The fourth module is ethics. Around the world, we have learned, and every time we're in countries, I often am presenting the ethics content, and so I'm always wondering and very cautious about, presenting perhaps our culturally biased thoughts about ethical issues. And yet in every country, nurses say, please talk to us. They talk to us about their moral dilemmas. Our fifth module is culture, because our goal is, of course, to talk about end-of-life care, knowing that there are tremendous cultural influences on death and dying and how we practice. The sixth module is communication, how nurses can use effective listening skills and communication skills to help patients to identify values and goals, to explain prognosis, to assist in family conferences. Our seventh module reminds us that nursing care doesn't end when the patient dies, but extends to the family during the bereavement period, and so we teach about loss, grief, and bereavement. I'll always remember teaching our first course in Africa, in Tanzania. As we stood up to begin to teach these nurses about bereavement, I realized that every nurse in the room, there were some Muslim women dressed in their bereavement attire, because part of their tradition was that if they had lost someone close in their family, that they wore particular clothing for a period of time. And so we stood up to teach grief, loss, and bereavement amongst people who probably everyone in the room had lost a child, and many other close people in their family. And so again, every experience of teaching nurses is an experience for us to learn what it means to do this care around the world. And our final module is final hours, because we know that there's special knowledge and evidence to guide us as we care for people in the final hours of life. So this curriculum has now been extended to 77 countries and 6 continents, and most importantly, it's been extended to the bedside of patients across settings of care. This is Rose Varani, and I always, every time I am honored or have the opportunity to speak about our work, I want everyone to realize that I'm here standing in front of you, but I'm a part of a team, and that team includes at the very front of the ship, the captain, Rose Varani. Rose is a nurse educator. Rose is the person who has helped develop the curriculum that you see here. We started with one curriculum, our core curriculum. We thought we were going to do 5 courses. We would be done.